It's my distinct honor to introduce our special speaker today, Dr. Samir Gupta from UC San Diego. Well, I don't think Dr. Gupta needs an introduction for this group, but I'll share some key highlights. So Dr. Gupta, he's a professor and a staff physician at VA at UC San Diego. He went to med school at University of Michigan, and then he came to UCSF for his residency and fellowship. And I have been told he was a co-resident with many of the distinguished faculty in the audience today. Dr. Gupta, he is a pioneer in the field of GI, and he has led multiple landmark trial on colon cancer screening and prevention, funded by NCI, VA, and multiple other institutions. As we all know, Dr. Gupta chairs NCCN's familial and genetic high-risk annual guidelines on colorectal, gastric, and endometrium guidelines, which is a wonderful resource for many of us who practice cancer genetics. Dr. Gupta also led the multi-society task force in 2020 for colonoscopy and post-polypectomy surveillance guidelines, and many of our faculty here were also part of the team. So we are so honored to invite Dr. Gupta to give a talk to us today on colorectal cancer epidemiology and screening in 2025. Where are we and where do we need to go? So please join me in welcoming Dr. Gupta. Thank you, Samir.
Thank you so much, Api. It's really pretty humbling for me to be back here amongst my mentors and old friends, and really my old stomping grounds. I did my internship here, and this is just a real thrill to be able to come here and give this talk. So this is a really vast topic, as I'm sure all of you would recognize. And what I'd like to do is really present what I think are some of the most timely issues as they relate to colon cancer epidemiology and screening. And we have a number of experts in this area in the audience and on Zoom, I'm sure, as well. And so I'm hoping that we can also engage in a conversation about where you think things need to go. So I'll just share with you, these are my disclosures, and I'll point out that I will be talking about trial results from a test made by Guardant Health as well as genoscopy. So I think it's helpful to have a patient context. And here, if you could put your primary care hat on for a moment, imagine we have a 48-year-old man who presents to established primary care. He's got a prior history of hypertension and obesity. There's no family history of colon cancer. And he had a prior referral at age 46 for colon cancer screening with colonoscopy, which he did not complete. And he might tell us, I try and do what my doctors tell me, but I've been busy with work and my young kids, and I heard I did not have to start until age 50. So some of the key questions for this patient include, what is his risk for colon cancer and how is it impacted by the changing epidemiology of colon cancer? What is the evidence base to support screening, and which test is best for this patient? And what is the role of established versus emerging colon cancer screening tests for him? So here's the outline. I'll touch on the changing epidemiology. We'll then move to talk about recent evidence as it relates to screening, both randomized trials looking at incidence and mortality, as well as data on emerging tests. And we'll also review some data on the trade-offs between emerging and established tests. And then I'll close out by talking about what I think are some of the key challenges and future directions we need to think about. So if we look at the last 20 to 30 years, we can argue that there's been a real colorectal cancer success story. So this graph shows time on the x-axis and the rate of colon cancer on the y-axis. The blue line shows incidence and the yellow shows mortality. And what you can see here is that for all groups combined, incidence and mortality have been improving dramatically. And we have attributed this to improvements in screening, reduction in risk factors such as smoking, and also improvements in treatment. But I'd submit to you that this really represents an incomplete picture. We're still having 150,000 new diagnoses a year, 50,000 deaths. And there are some underlying trends, and you can kind of get a sense for this where after about 2010, you see a flattening in the incidence curve and a flattening in the mortality curve. So there's something important going on here by age. And then, of course, this is in aggregate, and there are obviously differences in colon cancer outcomes occurring, for example, by racial and ethnic groups. So the first thing I'd like to point out is there are really generational trends in colon cancer that are going on. There are some that are well established, that are familiar to you, and there's some that are emerging that you may be less familiar with. So what we're observing is among people born 1960 and later, increasing incidence of early onset cancer. I think all of us know about this. But what is interesting is that we're also seeing increasing incidence among middle-aged persons, age 50 to 60, and we're seeing a flattening of prior decreasing incidence among people 60 and older. So this is really surprising because if anything, we just have more screening going on in the population, not less. The changing epidemiology is also occurring with some changes in the characteristics of colon cancer. We're seeing more rectal cancer and more distal cancer compared to proximal. We're seeing more distant stage cancer, which is also very unusual. And we're seeing increasing incidence across all racial ethnic groups under age 50. The other thing that's really striking is that these are birth cohort trends. And what we're seeing, you can see here, as indicated by the arrow, that if you look at Gen X, they have higher colon cancer rates than baby boomers, millennials more than Gen X and baby boomers, and Gen Z appears to be having the highest colon cancer incidence rate of any generation. And that's one of the reasons why me and a few other colleagues really think that we need to change the narrative. The focus in terms of the changing epi needs to not just be a conversation about early onset colon cancer, but really about birth cohort trends or birth cohort colon cancer. So the changes are impacting who gets colon cancer by age. So these pie charts show the age distribution of colon cancer cases in 1992 on the left versus in 2019 on the right. And what you can see here is that the proportion of cases that are attributable to younger ages has gone up. And so, for example, if you look at age 40 to 49, it was 5% in 92, and now it's nearly 9%. And if you look at age 50 to 59, it was 11.6% in 92, and now it's 20.5%. So what this means is that we have a younger age distribution, that the people who are getting colon cancer are at risk for more life years lost. Many of these people are too young to be screened, and they present with symptoms. So we have to do a really good job with making sure we pull out the needle in the haystack in terms of people with symptoms who have colon cancer. And then the other problem is that group that's 50 to 60 that's seeing more colon cancer cases, they're also the group that is less likely to be up to date with screening than older age people. We're also seeing that the changes are impacting who gets colon cancer by race and ethnicity. So whereas in 1992, about 76% of all cases were occurring in non-Hispanic whites, now it's 58.1%. And the groups that, some of the groups that are experiencing, are accounting for more of the colon cancer cases are actually at higher risk for colon cancer mortality. So if we look at Alaska Native and American Indian persons, so they're shown here in the purple, they've gone up from accounting for about 7.5% of cases to now a doubling, 14% of all cases. And if we look at Black persons, in 92, they accounted for about 7% of cases, and now they account for 10%. So the question is, one of the questions is, what can we do now to address the changing epidemiology? So of course, we need to invest in fundamental translational epidemiologic research to try to discover and understand the drivers. But this is not good enough. If you talk to patient advocates, families and patients who are experiencing early and middle age onset cancer, they'll say, we need something now. And I think that what we need to do as a GI community is make sure that individuals under age 45, that we're closing the clinical loop on the potential red flag signs and symptoms of colon cancer. And this is really us helping our primary care colleagues be able to identify the potential red flags of colon cancer, to triage these people to either immediate colonoscopy or guideline-based management based on the symptoms and the symptom severity, and then to really importantly make sure that they're closing the clinical loop. So such as with a follow-up visit within 30 to 60 days to make sure that if they didn't send a person for colonoscopy, that the symptoms have resolved. Because I think that we can all agree that almost all benign causes of these red flag signs and symptoms should improve, whereas colon cancer-related symptoms will not. And then the other thing that we need to do is that for individuals who are age 45 and older eligible for screening, I think there's increased urgency to get people up to date because now they're at higher risk for colon cancer than they used to be. So let's turn our attention now and talk about screening and the recent evidence. When I was a fellow here, we used to make the fellow sit in the first row and read articles and answer questions. I promise this is the only question I'll ask, and it's for the whole audience. And so the question here is, which of the following strategies have been shown by randomized controlled trials to reduce incidence and mortality from colon cancer? So we can have a show of hands. So how many think guaiac fecal occult blood testing? Couple takers. Okay. FIT. All right. The stool DNA FIT or Cologuard. CT colonography. Sigmoidoscopy. A few more takers. And colonoscopy. A lot more takers. Okay. Well, let's talk about it. Let's review the evidence. So I think all of you saw some of these headlines from a couple of years ago. One of the quotes from these headlines was, "Now a landmark study suggests the benefits of colonoscopies for cancer screening may be overestimated." And these headlines were in reference to this article from the New England Journal, where they looked at the effect of colonoscopy screening on the risk for colon cancer incidence and related death. And this was set in Norway, Sweden, and Poland between 2009 and 2014. And this is at a time where in these countries, there was no usual care population-based colon cancer screening. It was a randomized trial among about 85,000 individuals aged 55 to 64. And they compared invitation to colonoscopy, and this was nearly 30,000 people who were invited, versus no invitation. And so the comparison group was about 56,000 people. They did an interim analysis through 10 years of follow-up, and the primary outcomes were incident and fatal colon cancer. And the primary analysis, as expected, is an intent to screen analysis. But it's important to keep in mind that among those invited, only 42% of people accepted the colonoscopy invitation and actually completed the colonoscopy. So here are the main results. And first, we can talk about the graphs here. On the left is the curve for incidence. It's time on the x-axis and incidence on the y-axis. The red line shows incidence in the invited group, and the blue line shows the incidence in the usual care group. And as expected, in the invited group, we see an initial bump in colon cancer incidence. This is due to detection of prevalent cancer. After some time, the curves cross, and then the incidence rate is lower in the invited group compared to the usual care group. And this represented a nearly 20% relative reduction in the incidence of colon cancer. The story was different when we look at the mortality curves here, where we see almost complete overlap between the incidence and mortality curves. The point estimate for risk reduction was 0.9, and the confidence interval crossed 1, so no difference was found. They did do a per protocol analysis where they looked at people who were invited to screening and actually completed the colonoscopy. And in this case, for the incidence analysis, they saw a relative 30% reduction in colon cancer incidence. And for mortality, they saw a relative 50% reduction in mortality. So how do we explain these disappointing results? So some have brought up the potential for bias. One of the things that in terms of which patients elected to go for the colonoscopy in the colonoscopy group, so there was not a stage shift to earlier colon cancer in the screen group. And we would have expected that. We've seen that in most screening trials. And the idea here is maybe worried unwell people who had symptoms like belly pain or hematochezia more selectively, more commonly elected for colonoscopy than those who did not. There's questions about validity. So this is a trial of colon cancer screening, but only 42% of people accepted the colonoscopy invitation. We might need more follow-up time to see the mortality benefit. So if there's an incidence benefit, then the mortality benefit takes time. There are questions been raised about endoscopist performance. So about a third of the endoscopists had an adenoma detection rate of less than 25% in this study. Although, of course, we recognize that we have variable performance in the United States. And then some of the other counterpoints, we have many observational studies from the US, from Poland, Sweden, that demonstrate persistent and substantial lower risk for colon cancer incidence and mortality, including with up to 12 to 20 years of follow-up. So let's switch gears now and talk about recent evidence for sigmoidoscopy. And you might ask yourself, why am I going to present you evidence from a test that's almost never done for screening in the United States? And the reason is because I think these are among the most robust evidence to support the idea that endoscopic screening can reduce incidence and mortality. And we have a recent meta-analysis that represented a 15-year pooled analysis of 4 randomized trials with nearly 275,000 people. And here you can see on the left the incidence curve. The group that was invited to screening is shown in the black line, and the group that was not invited is shown in the dashed line. And you can see that after about 6 years follow-up, there's a persistent reduction in colon cancer incidence out to 15 years, and a similar benefit in terms of mortality that's shown here in the right curve. And for one of these studies, the UK FlexSig study, they have follow-up out to 21 years, and they found that exposing people to one-time sigmoidoscopy out 21 years still has an appreciable benefit with respect to colon cancer incidence and mortality. So here's my first scorecard. This is the summary of the randomized trial evidence. We have 1 colonoscopy trial that showed a reduction in incidence. We have 4 sigmoidoscopy trials that show robust reductions in both incidence and mortality. And we didn't go over these data because they're not recent, but we have 4 randomized trials of guaiac fecal occult blood testing where we've seen reductions in incidence and mortality. And I think the most important question here is, well, what about comparative effectiveness? We want to know, do we really believe that guaiac FOBT will have the same results as colonoscopy? I think we'd like to believe that colonoscopy would be better, but we'd like to see the head-to-head results. And in the next 3 to 5 years, we will see trials reported out, including the VA's CONFIRM trial, which randomized 50,000 people to FIT or colonoscopy. And so that'll give us a window into what's going on there. So what about the other established tests? So the second and third most commonly done tests are FIT and stool DNA FIT. So here we infer an incidence and mortality benefit based on the test characteristics in terms of sensitivity for advanced polyps and colon cancer, as well as observation and modeling studies. So just to remind you all, for example, for one of the most commonly used FITs, the OC sensor, the sensitivity for advanced neoplasia is about 25%. The sensitivity for colon cancer is 75%. The specificity is about 95%. And observational studies suggest a 21% relative incidence reduction. And there's one study that has shown a nearly 60% relative mortality reduction associated with FIT exposure.
Excuse me. I'm going to interrupt you once.
Yes.
Specificity is the specificity of a negative test, not of a positive test. 95% of a positive test, if that were specific, that would mean 95% of your patients positive test. You having a negative test, not having cancer.
Yes,
It's 99% with no test.
I'm.
The only reason you get 95 is when you do a 2x2.
It is a 2x2, and I'm sorry if I was misleading at all, but it's supposed to be either the proportion of people with a negative test, with no findings who have a negative test, or a proportion of people with no advanced neoplasia who have a negative test.
Specificity thing is a statistical bullshit detector.
We can debate this more.
No debate. That is
It's an indicator of the false positive rate. Yeah.
And of course, if you do no test, you can't not having cancer is 99%.
That's correct. Absolutely.
I'll save for later.
All right. I love it. I mean, this is no different than 30 years ago. So in terms of Cologuard, the sensitivity for advanced neoplasia is 47%. For the sensitivity for colon cancer is 92%, and the specificity is 89%. And we don't have any randomized trial or observational study evidence other than the test characteristics. So let's talk now about the recently reported out FDA approved tests. So these are what I'll call the emerging tests. We have a stool DNA 2.0, a stool RNA FIT, which was reported out, and a cell-free blood-based screening test for colon cancer. So a little bit about these studies. The DNA FIT 2.0 study, first of all, this is a brand new Cologuard. The only thing that is carried forward from the original test is that it still looks for fecal hemoglobin. And then it includes 4 new methylated DNA markers. That study included 26,000 people. They included 20,000 people in the analysis, and they observed 98 colon cancers. And they directly compared the test characteristics of the DNA Fit 2.0 to the OC sensor Fit. The RNA Fit test includes 8 RNA markers, and it also includes a Fit. And something unusual in this one is their algorithm that's used to call a positive or negative test. It also takes into account a yes/no answer as to whether the patient is a tobacco smoker. They included 14,000 people. They analyzed 8,900, and there were 36 colon cancers observed. And they did compare their test characteristics directly to the OC sensor Fit. And then for the blood-based cell-free DNA, so this is basically looking for methylation markers on DNA. It looks for aberrant fragmentation patterns of the DNA that can be associated with cancer, and then also at somatic pathogenic variants in APC and KRAS. And this study enrolled 22,000 people, but they did a stratified sample for the analysis of 7,861 people, including everyone who had colon cancer. There were 65. So I would characterize this as more of a nested case control study than a cohort study as compared to the other studies. So I want to just orient you to this graph because we're going to look at a bunch of data related to the studies. So we've got the different tests here, cell-free DNA, RNA Fit, DNA Fit 2.0. I've shown you DNA Fit 1.0. guaiac fecal occult blood, Fit, and colonoscopy. And in this case, we've got the sensitivity. So sensitivity for colon cancer was 83% for cell-free DNA, 94% for the RNA Fit, 94% for the DNA Fit 2.0. And this is compared again to Fit, 74% sensitivity, and colonoscopy, 95%. So we can argue that all emerging tests have better colon cancer sensitivity than Fit and guaiac fecal occult blood tests, and that the novel fecal tests are starting to approach here colonoscopy in terms of sensitivity. I'm sure we're all interested in the stage-specific sensitivity, and the chart at the top left shows the data for DNA Fit. It's in orange compared to Fit in the gray bars. The chart up here shows the RNA Fit in dark blue and the OC sensor Fit in the light blue bar, and then the cell-free DNA, there was no Fit comparison, so we just have the data for that assay. And I'll just caution here that the numbers for looking at stage 1 colon cancer are very small. So in the DNA Fit study, there's only 30 stage 1s. In the RNA Fit, there's 14. And in the cell-free DNA, there's only 17. So small sample size. But given what we see here, we can observe that the novel stool tests appear to have better stage 1 sensitivity than Fit, and that the cell-free DNA stage 1 sensitivity appears to be similar to Fit. But again, these were not compared head-to-head. And then all of the new tests appear to do very well, obviously, for the more advanced stage cancers. Mm-hmm. We do have that data, and I'm sorry I didn't create slides about it. I can definitely send some afterwards, but all of the studies did break out performance based on proximal versus distal. For most of these tests, the performance for proximal versus distal is consistent. The differences for Fit, the proximal performance is not as good as for distal, so Fit does better with distal. These are the data for the sensitivity for advanced polyps, and you can see here the blood-based test was only 13%, so that's almost the same as just average risk. That is a minimal increase in detection over what we expect the prevalence to be at screening colonoscopy, which is about 6%. The RNA Fit had 46% sensitivity. The DNA Fit 2.0, 43%, similar to the first round test. And here we can say that all emerging tests have lower sensitivity for advanced polyps compared to colonoscopy. The emerging tests have higher sensitivity than Fit, and the cell-free DNA test has lower sensitivity for advanced polyps compared to Fit, the DNA Fit 1.0, and the emerging fecal tests, and you might argue that has similar sensitivity as guaiac fecal occult blood. One place where there was some significant differences was sensitivity for advanced serrated polyps. So you can see here for Fit, it's 5%. The DNA Fit 2.0, it's 45%. The RNA fit is 22%, and then the cell-free DNA at 11%. So here, this is one of the challenges with FIT is it's not a great test for serrated polyps, and that the sensitivity for serrated polyps appears to be better for the DNA fit. Here are the data for specificity in those without advanced neoplasia. So there are different definitions and numbers for specificity that are presented in this paper. The one that all of them are consistent about is that they present the proportion of people who had non-advanced adenomas, non-neoplastic findings, or negative colonoscopy who had a negative test. And here you can see the specificity for the cell-free DNA was 90%, the RNA fit 86%, DNA fit 2.0, 93%. We can argue that that really was the main change from the DNA fit 1.0 to the 2.0 is that the specificity improved. And then you can see here that for the specificity for advanced neoplasia for FIT is 97%. So the specificity remains better for FIT compared to emerging tests. Here, I think it's worth digging a little deeper into the specificity data. This graph shows the age-specific specificity for advanced neoplasia. So you can find these data in the supplement or the FDA submission data. And the first, on the x-axis here are age categories. And the first thing that I'll point out to you is the top blue line, which is the specificity for FIT across ages. And you can see here, it really doesn't budge much. It goes from about 96% to 94%. That's in contrast to all these other tests where, for example, you can see for the cell-free DNA test, you see a drop in specificity from 93% to 80% when you get to age 76 and older. And for the DNA fit 2.0, similarly, you start at 95% for very young people, 40 to 44, and you drop to 85% as you get to older people. And so this might suggest that it would suggest that the false positive rate is going to be higher with these emerging and alternate tests as you get with older age. So I think we'd all be curious about the comparative effectiveness. There's no head-to-head data other than these test characteristic data where they're comparing it directly to FIT. And so here we really have to lean on modeling studies. And the person who's been writing the most compelling articles about this is Yuri Lademam from Stanford, who of course was on faculty here. And this paper came out in the Annals a couple months ago that looked at the projected impact and cost effectiveness of novel tests for colon cancer screening. And there are a ton of data in this paper. I just want to focus on 3 questions that they answered in the paper. One was, what is the relative effectiveness of emerging versus established tests? And again, this is modeled effectiveness. One of the questions regarding the blood-based test is, since it has lower sensitivity for colon cancer, is how much better does participation have to be for it to achieve equivalent benefits? In this case, they used as their comparative equivalent benefits to screening with FIT. And then the other concern is, is it possible that a bunch of people who would have otherwise had a colonoscopy or done a FIT are now going to do the blood test? And there we worry because the sensitivity is lower that there might be harm. And so the question there is, at what balance of substitution of established tests versus getting additional people screened could blood-based testing result in population harms versus benefits? So the key assumptions in these outputs is that you have 100% participation in the strategy and perfect follow-up. So if you have an abnormal non-invasive test, that you always get a colonoscopy. And then the FIT sensitivity that was modeled was 67%. This is from the Imperiale New England Journal study. And this sensitivity number is the lowest of all large studies that have been done of FIT, of the OC sensor FIT. Usually it's about 75%. So this chart first shows the effectiveness data. And just to orient you, on the left are the number of colon cancer cases per 100,000 population. And on the right is the number of colon cancer deaths per 100,000 population. The black bar shows the number of cases and deaths that you'll see if there's no screening. So the first comparison we can take a look at is boxed out here in red. So this is the cell-free DNA test done every 3 years. And here you can see the projected effectiveness would be about a 40% relative reduction in colon cancer cases and about a 55% relative reduction in colon cancer deaths. In the middle here are the data for the DNA 2.0, the stool DNA 1.0, and the RNA fit test. And here you can see the projected impact is about a 70% relative reduction in incidence and about a 70% reduction in mortality from colon cancer. And then the well-established test for FIT. So interestingly, for FIT, which is shown in that first brown bar, about a 70% relative reduction in colon cancer cases and about a 75% reduction in relative deaths. And for colonoscopy, they modeled an 80% relative reduction in colon cancer cases and an 80% reduction in colon cancer deaths. So then the second question is, what blood-based participation rate is required to achieve similar FIT outcomes? And there are a lot of data in the paper, and I just pulled out a couple examples. So if we think about a group that has 40% FIT participation, to achieve a similar number of cases prevented, the screening rate with the blood-based test needs to be 68%. To get the same number of deaths prevented, they would project you need about 54% participation. And if you want to get similar number of quality adjusted life years gained, you need participation of about 53%. If your FIT participation is even higher, and it's rare to find this kind of participation, but if it's 60%, there's no way that the blood-based test can match FIT in terms of the number of cases prevented. So the question here is really, what are the real world participation rates and what will they be for the blood test? The second graph here, the second chart here I want to orient you to. So this is that question of additional screening versus substitution of established screening effects. And here we define addition as the absolute fraction of the population among the 40% who are currently unscreened for whom the blood-based test was added. Substitution is defined as the absolute fraction of the population among the 60% who are currently up to date with colonoscopy or FIT for whom the blood-based test is substituted. And the outcome here that is presented is the percentage change in the about 2,000 colon cancer deaths per 1,000 people, 100,000 people that we project is currently occurring. So if we have no substitution, so that's shown in the first row, and you have a 10% addition in the screening rate by doing the blood-based test, you get a 9% reduction in the, you get a 9% change 9% percentage change in the colon cancer deaths per 100,000 population. And if you get to 20% additional screening, then you get a reduction by 18%. So if you have substitution effects, which we're going to expect that there are going to be some, and you have 10% substitution, if you have 10% addition, you about break even. That's right here in the middle. If you have 20% addition, that's when you start to maybe come out ahead by having the blood-based test there. If you have a lot of substitution, 20% substitution, then you got to get at least 20% more people screened with the blood-based test to start to break even in terms of your population benefits as far as colon cancer deaths. So the bottom line here to me is that the impact of emerging tests, particularly blood-based tests, is going to be most sensitive to the relative impact on participation. And this means that how clinicians present these options and how patients perceive the tests will be really critical to the future impact, both on a personal level for patients as well as on a population level. So now I want to switch gears and talk for a few minutes about challenges and future directions. And we'll talk about the challenge of getting people to participate in screening as well as abnormal test follow-up. So we know from national data that uptake of colon cancer screening is suboptimal and that it varies across the population. So this 2021 estimate, which is the latest that I'm aware of that's available, projects that about 59% of the age-eligible population is up to date with screening. And we see lots of variation by different groups. So we see lower screening rates among younger individuals. We see lower rates of screening among American Indian, Alaska Native, Asian, and Hispanic persons. There are gradients by education with lower rates among those with less education, by income, and then lower screening rates are seen among those who have Medicaid and, of course, who are altogether uninsured. So we still have a lot of work to do here. And the time trends here is this has really not budged much over the last 3 times that we've checked it. So what are the opportunities for addressing screening rates? Well, the good news is there are multiple very well evidence-based population and patient-level interventions for promoting screening and follow-up that exist. So the 2 that I think every health system needs to implement, number 1 is test choice, so offering a choice of colonoscopy and at least 1 non-invasive test such as FIT. And this really goes back to pioneering work that John Inadomi did at San Francisco General Hospital about 25 years ago, where he showed that offering a choice of test resulted in higher screening participation than just offering colonoscopy alone. The other evidence-based strategy is mailed FIT outreach. So I think all of you are familiar with this. This is a mailed invitation that includes a FIT kit and some reminders. Ma has done pioneering work in this area. Meta-analyses of randomized trials have shown that mailed FIT outreach is associated with a 22% absolute increase in screening participation over usual care. Again, Ma did one of the best studies of cost effectiveness and showed that it's cost effective. We did a randomized trial where we compared mailed FIT outreach to usual care as well as in-reach. So this is in-clinic education, and this is because some people were resistant to rolling out mailed outreach because they said, well, we should just be doing stuff in the clinic. And what we showed was that mailed FIT outreach was superior to both usual care and in-clinic navigation for screening completion. And then Chaik Dubani and Doug Corley have reported out the Kaiser experience that when mailed FIT was rolled out as part of their screening program, that this is also associated with elimination of Black versus white person differences in colon cancer outcomes. So what are the future directions for participation? So one is I think we need some comparative effectiveness studies of outreach offering FIT versus the other non-invasive tests. So the company makers might argue, well, it's a test you can do every 3 years, and we've got all this navigation built in. We call people, we harass them, we try to get them to do the test. But for all the money, the extra money it costs for these tests, I think we need to really see that outreach programs using these tests are better than what we get with mailed FIT, which is already well established. I think the other thing that we need is to see studies assessing the impact of novel tests on increased participation versus substitution. And there's been one good study of this so far by Peter Leung, where in the VA, they saw minimal substitution of colonoscopy or FIT by the serum septin 9 test, which is actually no longer on the market, but it was one of the first blood-based tests. And then I'm pretty excited. We just got pilot funding from a group called CureBound to do a randomized trial in partnership with a federally qualified clinic, where we're going to approach people having a primary care visit who are age 45 to 75. We're going to randomize them to the usual care options of FIT or colonoscopy and some telephone reminders. And we're going to compare this to the option of at-home FIT, colonoscopy, or doing a blood-based test in the clinic and being sent home with an at-home FIT. And we're going to look at screening completion and relative substitution effects. So the other main challenge that we have is follow-up of abnormal tests. And I actually think as a GI society, we really need to lean into this because it's going to become even more of a problem. So it's been observed that completion rates for colonoscopy after an abnormal fecal test, they range 18 to 69% nationally. It ranges 18 to 57% in one study we did of Southern California Federally Qualified Health Systems. The goal is 80%, and that's because a lack of completion is associated with a 2-fold increased risk for colon cancer death. And this is because, for example, about 1 in 20 people with an abnormal FIT have cancer, and 1 in 4 have a large polyp. So what are the opportunities for addressing this? Well, one is patient-level navigation. That looks like it works. At the provider level, reminders and performance feedback. At the system level, again, Ma has been doing some amazing work in this area, thinking about automated referrals, pre-colonoscopy calls, patient registries, and even just putting on the problem list that someone has an abnormal fecal test. And as I was saying, this is gaining increasing importance. The number of people screened with non-invasive tests is likely to increase, and we really want to take responsibility for this. And this problem is not solved by having a novel test. So Cologuard follow-up in one national survey was just 62%. So they might be doing better, but not enough. So what can we do? One is there's a continued need for innovation, and we have shown that 80% completion is achievable in integrated health systems. So this is really Kaiser. We've seen more mixed results in non-integrated health systems, such as federally qualified clinics. So, for example, I was really disappointed. We did a study where we implemented navigation and a checklist, and we could only improve the screening rate in one federally qualified, the follow-up rate from 21% to 38%. So we need randomized trials of novel interventions. We know that navigation is probably necessary, but is definitely not sufficient. But I think the biggest game changer would be if we can all get behind a health policy intervention. Again, Ma has advocated for this, and that's really to implement an abnormal test follow-up quality metric, which would be the proportion of people with an abnormal non-invasive test who complete colonoscopy within 6 months. And the goal is 80%. And the benefit of this is it would achieve reduced colon cancer incidence and mortality if we have more completion. And we really need to fight for this. So back to our case, I think in the case of this individual, I'd want to explain that colon cancer incidence is rising and that screening can reduce incidence and mortality. I'd want to offer a choice of strategies and pick the one based on their preferences, see whether they put a big weight on test sensitivity and effectiveness, or whether they put more weight on the convenience and acceptability, and then to put in place systems to promote completion, like mail fit outreach and follow-up. And this is my final scorecard, which is really where are we and where do we need to go? So current state, the epidemiology of colon cancer is changing with more early and middle-aged onset and persistent disparities. So here we need to discover what are the etiologic drivers, achieve high rates of participation by implementing evidence-based strategies, and to promote awareness and diagnostic resolution of symptoms, particularly in those who are under age 45 not eligible for screening. We've shown that randomized trials can reduce incidence and mortality, but we don't have head-to-head studies that have been reported. And so, of course, we need the results of these studies with longer follow-up. We have multiple established and emerging tests where we don't have randomized trials. There's highly variable sensitivity, and some of these tests are very expensive. So here we need comparative studies of participation, including relative substitution of established tests by emerging tests. And then finally, as we just mentioned, abnormal test follow-up is suboptimal. And here we need novel interventional trials and a quality metric that promotes tracking and follow-up of people with abnormal tests. So I just want to thank you all for your attention, recognize my grant support. I want to recognize one of my mentors who's here, Jim Allison, made a big effort to come over here from the East Bay. I don't think I'd be doing this work unless we'd had really spirited conversations and his support all along the years. So thank you so much for your attention.